I really kind of my desire and my plan when I was talking with some of my marketing team about Women's Health Month was just to really spend time helping women know and understand menopause, perimenopause, what it is. Like there's so many different definitions around it. There's a lot of confusion around it a lot of times. And so this is really just a night that I want each of you to have, hopefully get some education, some understanding about it, but then also be able to just ask questions and maybe even be able to share our individual stories. So this topic, again, is something that I think is very overlooked and unfortunately not spoken of much in the traditional world, in the functional world of medicine. And it affects millions of women every single year. And so I think it is something that we really could do a better job at educating and treating. There is nothing here in this tonight that I'm trying to sell anything or anything like that. So this is truly just for you guys and hopefully to provide some education on that. So it's kind of interesting. I wanted to kind of just share this quick story before I jump in. When I first started at Allina, I will never forget the first woman who sat in my clinic room and just shared what she was going through with regard to menopause and how she was feeling, and just all of the symptoms that had come along with that. And I remember just feeling completely hopeless and like, I need to help this woman and I have no idea what to do. I was pretty fresh out of school at that point. So that was like 13 years ago. So my first job as a nurse practitioner was at Allina in Shakopee. And we were at the clinic where we had other specialties there. So I was able to go down the hall and talk with one of our gynecologists about this patient. I'm like, hey, here's what's going on. I'm not exactly sure what to do with her. And I still remember his words to me were, we can help her with her hot flashes and her night sweats and her vaginal dryness, but that is all. There's nothing else we can do for all of her other symptoms. And I just remember being like taken back and feeling like helpless. Like I can't go back in this room and tell this patient this, like, this is not okay. So fast forward, I did not realize that this would be a big part of what the Lord had called me to do and kind of where I would be in my practice, 13 years later. But it truly is one of my favorite pieces of working with people. And it's challenging. It's a super challenging time to help women through. But it's super rewarding when you're able to see such big changes and help them change the trajectory of their health. So that is kind of my initial background in menopause and my first time and what part of why I'm so passionate about it. So we'll kind of dive in. Really, I think the best part of this whole talk tonight is going to be Tara and learning from her and her story. So I don't want to take up a lot of time before that, but I do think there are some kind of important key things that we should talk about. If you do come and see me, you know that I am a little type A. I like a plan. I like structure. So here's our plan for the night. A lot of women come in and talk to me about, why is there conflicting information? My gynecologist tells me this, and my PCP tells me this, and then you tell me this. So we're going to talk about that a little bit and where that comes from. We're also going to talk about just putting some clarity behind what is perimenopause, what is menopause, what is early menopause, what is late menopause. There's just a lot of different terminology that can be used, and so hopefully provide a little understanding around that. We're going to dive into a little bit of the WHI study, the Women's Health Initiative study, to help us better understand why there's such a stigma around menopause and menopause treatment and therapy. So we'll dive into that a little bit. And then we'll talk about some different menopause myths, and then we'll end with the best part of the webinar with Tara. So that's my plan. Like I said, feel free to ask questions in the chat or even just on your mic. I'm totally fine with that. So one of the biggest things I hear probably every day is, who do I believe? Do I believe my gynecologist, my primary care provider? Do I believe you? Like, what is going on and why is there so much conflicting information? And so everyone should truly know that medicine is not black and white. I think a lot of times patients think that, like, oh, there should just be an answer for this or this, but it doesn't work that way. And so menopause and perimenopause is one of those times, those situations that we see a lot of conflicting viewpoints from different types of providers. Some of the reasons for that I have listed out here, and I can relate to pretty much all of these just because I was traditionally trained initially as a nurse practitioner and then got into more of the functional world on my own, um, by my own desire. And so traditionally trained practitioners really don't get taught all sides of menopause, perimenopause, and treatment. We're really just taught one side. If this is not a specialty, you could very well find yourself in that provider's office who was like me when I was new. And I'm like, I don't even really know what to do with this person because that's not my specialty and I don't see a lot of it. So unfortunately, sometimes you hear information and recommendations from providers that just aren't super educated on these topics. Sometimes we just have providers who are very old school, and I say this with love and kindness, but they just have a hard way of changing their viewpoints and their practice styles. And so that can be a little bit difficult to manage as well. And then the biggest thing, I think, why we have such conflicting information and viewpoints from providers is that people do not truly take the time, practitioners do not take the time to really dive into the research, the updated literature, and really understand, okay, what is best practice truly? And so, in my opinion, that gold standard for what do we actually believe, where do we get our information, is that it has to come from quality research. We have to, as practitioners, we really need to be staying up to date on what those changes are and what those studies are showing us because they are constantly changing. If you are somebody who enjoys studies and reading through those, which there are a few people who do, even though they can be extremely boring. Really watch out for bias in the study. And before you even dive into a study, figure out, who are these people? What is their purpose and their goal behind this? Because a lot of times studies can be misleading and really trying to point to the outcome they're wanting to help them in some way. So just be careful of that in general when you're looking at research studies when it comes to medicine. So what the heck is perimenopause and menopause? This can, again, be a little bit confusing because there are so many terms around that. So truly, perimenopause refers to a time period for over about 10 to 20 years. And during this time period, this is when the female body is transitioning from having a regular monthly cycle, menstrual cycle, to amenorrhea, just meaning you haven't had a period for at least a year. A lot of people don't realize this, but perimenopause really can start as early as age 35. And so it really does impact us for a pretty significant period of our lives overall. One of the things that I always find the most interesting about perimenopause and menopause is the extreme fluctuations in hormone levels. It's what we call the roller coaster effect of that. And what that means for the patient. And this is why it's so challenging to really help patients during perimenopause specifically, because these hormones are constantly fluctuating. But if you listen and you understand what's happening, sometimes it can make it a little bit easier. And I think me spending a little time educating you tonight will help you, even yourself, know, oh, I might need more progesterone if I'm feeling this way versus estrogen. So when we are born with a set number of eggs. And so that amount of eggs literally is when we're conceived. And then by around the age 40, we have our egg supply has diminished to about 3% of the total egg pool of which we were born with. So every time we have a period, we ovulate, we release an egg. That egg has something called a corpus luteum. That corpus luteum of the egg is what produces progesterone. Progesterone is very important. It's kind of the anti-estrogen. It helps keep estrogen in balance. So hormones, for the most part, are really, really good, but they can also be really, really bad if there's too much or not enough of them. And so this balance is very important. So when we look at progesterone and it's only being released anytime an egg is released because of that corpus luteum, what we'll see is that progesterone levels actually start to diminish sooner than estradiol levels. And so we'll sometimes have periods where we have super high estrogen-like symptoms like bloating, breast tenderness, headaches, swelling. And that is because that progesterone isn't there to counterbalance the estrogen. Then we'll have times where we cycle and we do release an egg, so we do have progesterone, and then maybe we have the reverse. Maybe we have a little bit too much progesterone, or maybe our estrogen symptoms are in check, they're doing good. And so you will have this constant fluctuation in those hormones during that perimenopause time. So there are a few terms to kind of be aware of when we're talking specifically about perimenopause and menopause. So that what you might hear referred to as early menopausal transition is it's a perimenopause time, and this is where typically we'll see. So it's early in the whole menopause cycle, and you're going to have it's usually more short cycle, short cycle intervals, and they could be fewer than 21 days. So this is where you might have that, oh, I got a period now, and then a week later, I got another period. And usually your menopause symptoms are a little bit more subtle, and they're not as significant during this kind of early menopause transition time. When we transition into late menopause, so still perimenopause, not yet menopausal, then those intervals can become longer. So you might have, periods where you go 2 months or 3 months without a period. And that's really more of that late menopause transition. This late menopause transition time usually lasts somewhere between 1 to 3 years. So it can really vary depending on the patient. And this is typically where we'll start to see symptoms get worse. So those hot flashes are worse, those night sweats are worse, the vaginal dryness is worse, all of those types of things. And then we have truly menopause or post-menopause, and that simply refers to you have not had a period for 1 year. So if you don't have a period for 11 months, you get a period, that is not menopause. So it has to be that full year, which I think is kind of a silly definition of this, but that's how it is. That's what it is. Early postmenopause is kind of that time where you haven't had it for 12 months, and you can still have some of those hot flashes and night sweats. And then late postmenopause will be several years after that period, that final period. And usually we'll see the hot flashes and night sweats start to diminish over that time. However, during that late postmenopause time is really where we see increased risk and increased incidence of things like heart disease and osteoporosis. So even though we're not as symptomatic, the changes happening internally and inside can be pretty significant and really put us at risk for other disease processes. So there are a few different types of menopause that I just wanted to touch on in case you guys have heard these in the past. So there's something called premature ovarian insufficiency. And this is any of those women that we're seeing go into menopause before the age of 40. So that just simply means your ovaries are not working well at a very young age. Then we have early menopause, and early menopause is really referring to those women who go menopause. So they're post-menopause between ages 40 and 45. And then we also have women who experience surgical menopause, where their ovaries were removed for various reasons. And so that induces menopause for them, along with all of the symptoms and comorbidities that can happen following menopause. So this is another really important thing that I wanted to make sure we touched on tonight is are my symptoms menopause? Am I just crazy? What is going on here? And a lot of times women, there are some common menopause symptoms, which we'll talk about, that they know, and they're like, oh yeah, that's menopause. And there are times they're like, I don't know what this is. Is this normal? Is this menopause? Is this not? You go to your doctor and their kind of response is, well, it's just what it is, right? You're getting older. Or you're stressed, or you're anxious, or things like that. You have kids, you're not sleeping. So of course you're gonna have these symptoms. So common kind of classic menopause symptoms are going to be those irregular periods, the hot flashes, the night sweats, insomnia, which can mean not, falling asleep, not falling asleep easily. So taking a while to fall asleep. It can mean not staying asleep. And then it can mean truly just not sleeping all night. So there's different variations of insomnia, vaginal dryness or dyspareunia, which is that pain with intercourse. Mood swings, and this can be anything from panic attacks, depression, anxiety, irritability. I remember a woman sitting in my office telling me she wanted to all of a sudden hit the babies and kick the grandmas, and she's like, I don't know why I'm feeling this way. That's not normal. And so we see some of that as well. Weight gain is a pretty common one that we'll see. Memory loss, brain fog. I have irritability twice. Apparently that's fairly important. Low energy, obviously some libido changes. Again, we talked about headaches and bloating. Hair thinning and hair loss is a big one, and I hear a lot about that. joint pain, breast tenderness, that fluid retention, like we talked about with the progesterone and estrogen imbalance. And then frequent UTIs is another one that we'll see pretty commonly during menopause and perimenopause. And then skin changes as our estrogen drops and our elastin and collagen go down. So the SWAN study was a pretty big study just assessing women and what their symptoms were around menopause. And what they found was the median duration for hot flashes or night sweats was about 7 to 10 years. So on average, women are dealing with hot flashes or night sweats or those vasomotor symptoms for about 7 to 10 years, which is pretty crazy. The other thing that they found was that if you start having hot flashes and night sweats in that kind of post-menopause time, so after you already stopped having a period, usually you had a shorter duration of those hot flashes and night sweats, so usually around 3 years at an average level. The other thing that I found really interesting when diving into the data about this was the percent of depression increased in women from 20% to 62% in that perimenopause and menopause time. So again, that can be a tricky conversation, a tricky subject. What's going on with me? Am I normal? Am I not normal? Like, what's happening? And that's a very, very common thing that we see with menopause and the change in our hormones. Some of the more uncommon menopause symptoms are going to be things like numbness or tingling in your extremities, burning mouth, electric shock sensations, itchiness, muscle aches, some food sensitivities, and GI symptoms can also happen here, along with some heartburn or reflux-like symptoms. Food cravings, changes in taste, brittle nails, again, some urinary symptoms. Those are the genitourinary symptoms, which we'll talk about a little bit later. Dizziness is actually another common one that we can see. Allergies all of a sudden developing, irregular heartbeat, and then osteoporosis, which we'll touch on a little bit deeper here coming up. Bone health is one, there's a few specific topics that I really want to touch on to know, like, what's the risk of menopause? We don't really think about it that often in that way, but there truly are some risks associated with natural menopause. So hormones are our fuel, and you might hear me say this later, but hormones, testosterone, estradiol, progesterone, our hormones are truly the fuel, our sex hormones that keep our body working well. And so part of what they do, we have over 400 receptors for testosterone, for estrogen, all over our body, from our brains, our breast, our bones, our heart, literally everywhere. And so when we have this reduction in these levels or no production of hormones, what starts to happen is we start to lose bone density, or we start to have heart disease and things like that. So I just want to spend a little bit of time diving into kind of some of the really important ones here. So bone health is one of the biggest ones that we see with low estradiol and testosterone. And the interesting thing here is that the most progressive and rapid bone loss begins 1 year before your final period. So we typically don't think about even checking for osteoporosis until our 60s. And that, I think, is too late, because we can really see a significant bone loss before that first year of the last period. When women haven't had menses for 3 months or more is typically when we'll really start to see that decrease in bone density. And then that rapid bone loss really continues for about 3 years after menopause, like post-menopause. And then the decrease or the decline in bone density tends to slow down a little bit to about 2% a year. Cardiovascular disease is another big one. So cardiovascular disease is the #1 killer of women, and this is most common, again, postmenopausally. So the risk of cardiovascular disease increases most dramatically in our peri and postmenopause time. An interesting thing here, so you can kind of put yourself in this situation and know, is that very frequent and intense vasomotor symptoms, so those hot flashes, night sweats, have been shown to have a pretty significant correlation with a higher risk of developing cardiovascular disease over about a 14-year period, is what this study was looking at. So if you have severe hot flashes and night sweats, those vasomotor symptoms, there is a higher likelihood of you having some cardiovascular disease postmenopausally. So something to be aware of, and something to really make sure you're keeping an eye on. And then your genital urinary symptoms. So this is going to be our vaginal dryness, our pain with intercourse. So vaginal atrophy occurs, again, because of that decrease in vaginal collagen and elastin, which estrogen is really responsible for that vaginally in our skin, kind of all throughout our body. And so when we see that estrogen drop, all of a sudden we lose collagen and elastin in the vaginal area. We also have an increase in our vaginal pH. And so all of these things can lead to, again, dyspareunia, or that painful intercourse. We're seeing frequent UTIs or yeast infections. 40% of women report sexual dysfunction in that peri and postmenopause time. The interesting thing here is that peri and postmenopause, that time really correlates with our highest rates of divorce, which is super sad to think about. But it makes sense because we don't feel the same. We're moody, we're irritable, we're depressed, we don't have motivation, we're bloated, so we feel fat and don't want to have sex, and then it hurts to have sex. And so, of course, this is going to affect our relationships. And so helping women and men through this time can really impact long-term relationship outcomes. So the WHI study is, I would say, the thing that really started to create all the confusion around menopause. How do we treat menopause? And just what scared a lot of providers and women. And that's really when everything changed. So it's called the Women's Health Initiative Study. It was initially started back in the early 1990s and then continued through to 2005. We actually are still doing some follow-up studies on that. But what you guys need to know, and this is where, again, some of that confusion comes from, is that this is where they looked at something called MPA, which stands for medroxyprogesterone acetate. And this is an oral synthetic progestin, okay, or progesterone. They also were using, if you look into these studies, it's called CEE, or conjugated equine estrogen. And so this was estrogen that they got from pregnant horses' urine. And this was what they were giving to women during that postmenopause time to help with, again, bone density and heart disease and vasomotor symptoms and all those things. Well, this study halted pretty quickly because there was a huge increase in heart attack, stroke, pulmonary embolisms, or lung blood clots in the lung, breast cancer. And so it was pretty quick that this study was like, okay, we got to stop. This is not good. And from that study, which is where a lot of providers still refer to when they're looking at hormone therapy, is all hormone therapy is bad. That was kind of the conclusion that was made and sent out to everyone. And so it scared women, it scared providers, and that really has changed the way that we treat women. So the follow-up to the WHI study with the same researchers came forward. I think it was recently, back in 2002, I want to say, was their update. And the researchers themselves reported flaws in the studies, but they also recognized the difference between different types of hormone therapy, which is super important. So we'll talk about this a little bit here later, but when we're looking at hormone therapy, if we are using synthetic hormones that do not match what the body naturally is making, we absolutely will see an increased risk of heart attack, stroke, breast cancer, all of those things. That is one thing that all providers are in agreement with. Synthetic hormones are not great. The one thing that you will see a little bit of use, which I don't necessarily love, is a bioidentical estradiol, and we'll kind of get into what that means exactly. But bioidentical estradiol orally. So if you're taking estradiol by mouth, we also know that it impacts your protein C, your thrombin, your clotting cascade. And so there is a higher risk, even if estrogen is bioidentical, if you're taking it orally, which is where some patients are told, we only want you on hormone therapy for this length of time because then it's too high of a risk. So again, if that's an oral estrogen, that is true. So that's one of the reasons I don't love oral estrogens, but we'll get into that as well. The other thing that I thought was super interesting from the WHI study is when they did their 10-year follow-up on the women who did have this hormone therapy, what they found was women were treated either with estrogen only or the estrogen and the MPA, the progestin. So we have kind of two arms, the estrogen only arm and the estrogen progestin arm. And what they found was the estrogen only arm actually had lower incidence and rates of heart attack and cardiovascular disease. And it also had reduced rates of breast cancer. So even though it was an oral estrogen, their heart attack rate, their heart disease rate, and the breast cancer rate was less in women treated with estrogen only. So that is where, again, a lot of the confusion is from. It's where a lot of providers, how they practice and what you guys are told when you go in, you're like, how is this information so different from what I'm hearing in other places? So let's dive into a few of the myths, and then we'll get to Tara. So one of the things that I hear a lot from patients who come in, oh, my provider told me that hormone therapy causes breast cancer. This is completely false. There are a couple of studies, one really pretty recently, I think it just came out in April, that showed actually a reduction in breast cancer in patients receiving estradiol by 22%. I did list on here kind of the references in case you are a nerd like me and want to dive into those, and I have them. If you want me to share them with you, I'm more than happy to do that as well. But I did list them out there just so you know that these aren't opinions just coming from me, but these are truly coming from literature. We also found that estrogen replacement does not increase the recurrence or the mortality after breast cancer. So this study was looking at women who had previously had breast cancer and were treated with estrogen. What was their recurrence rate of breast cancer, and then what was their mortality rate? So the mortality rate was 22.2% in hormone users, and the non-hormone users' mortality rate was 45.5%. So their death rate was much greater in the non-hormone therapy users. There was a 20% reduction in the mortality so there were 3 different studies that we were looking at here that this researcher had combined and kind of looked through each of them. And so that's what those 3 bullet points are there. So the second one that they looked at and compared showed a 20% reduction in mortality from breast cancer in estrogen users. And then that last one was estrogen users' mortality rate was 6%. Versus a 33% mortality rate in those women who did not use any hormones. So pretty convincing research that breast cancer is not caused by hormone therapy or by estrogen. Estrogen does not cause breast cancer. In fact, it really can be argued that it's opposite. It helps prevent it, and it helps prevent mortality and recurrence of breast cancer. The second myth here is that hormone therapy is bad. I would also argue that this is false. That being said, there are a lot of things in this world that can be good and bad. And so there are some times where hormone therapy is not done well, and it can be bad depending on who is treating you, who's using it, and how educated they are on it. But for the most part, hormone therapy is not bad. And here's why. So we kind of talked about this a little bit, the bone density piece, the Alzheimer's and dementia, and then the heart piece. But I wanted to pull out some statistics from some of the studies. So the first one there is looking at bone density. And what they found was an 8.3% increase in bone density after 1 year of hormone replacement therapy. So just 1 year of getting those hormones up, that bone density increased by 8.3%. This was using subcutaneous implants. The reason for that is when we're, again, taking oral estradiol, it goes through the liver. And so you don't have as good of bioavailability of that estrogen. The awesome thing was that when they rechecked these patients' bone density in 8 years and 10 years, that bone mineral density was maintained. So pretty amazing results just for treating, with hormone therapy for a year. What we know from the literature is that we need to have an estrogen level of at least 30 for us to see those improvements in bone density. There is also a 30% increase in skin collagen and 25% increase in skin thickness in these studies, in that same study that they looked at the bone density. So this is pretty amazing. And I say that because, again, I come from this traditional world where we really were, told there's really nothing we can do to treat bone density. We can just try to hopefully prevent it from getting worse with some like Fosamax and things like that. And so this is awesome that we can actually increase bone density. The second study there was looking at Alzheimer's, dementia, and what they found that, again, after at least 1 year of hormone replacement therapy, there was a reduced risk of Alzheimer's and then improved cognitive function, specifically verbal memory. So all those times that you're like, oh, what was that word? Like you just lose it all of a sudden. That's what that was looking at. And then the last one were several studies really looking at cardiovascular disease, heart failure, heart attack, and no increase in stroke. So the first one was we saw an increased 10-year survival rate after. So these are women who had already had coronary artery disease, and they were scanning their coronary arteries to see what their how significant their disease was. And what they found was that hormone therapy users had a 97% survival. Non-hormone therapy users had a 60% survival with that coronary artery disease diagnosis. It also found that estrogen lowered the LDL, which is the bad cholesterol. That's a whole nother topic. But it lowered that LDL by 11% and increased the HDL by 10%, which HDL is your good healthy cholesterol. We also see hormone therapy improves blood pressure and lowers blood sugar. And then a lot of times I get people in my clinic for this reason specifically is body composition. So as we lose testosterone and estradiol, we tend to see a significant increase in our fat mass. So giving testosterone and estradiol can reverse the decline of fat-free mass or the decline of muscle mass and improve that body fat distribution. Okay, here's another one that I hear all the time in clinic. Hormone therapy causes blood clots. That is not, again, completely true. So there are several studies that have been done. The ESTER study is one of the main studies that have looked at this. And that is where I was kind of referring to. The oral estradiol can increase clotting risk. So again, heart attack, stroke, pulmonary embolism, those types of things. However, micronized oral progesterone and non-oral estradiol forms do not in any way alter your clotting cascade. And therefore, those do not cause heart attack, stroke, blood clot, any of those things. Here's another one that I hear pretty frequently is, okay, so once I hit menopause, then everything's done, right? Like my symptoms are all going to go away. That's not necessarily true. Remember, those vasomotor symptoms can last on average about 10 years. And then post-menopause is where we really start to see the decline in memory, in your heart health, in your cholesterol, your blood sugar, your bone density, your blood pressure, all of those things. So menopause really, unfortunately, doesn't really end. Hormone labs don't tell us anything. I don't know if any of you have been to the doctor and asked for labs and have heard this, but I hear it a lot. They're like, well, they just told me they wouldn't draw because they wouldn't tell us anything anyways. This is also not true. You have to be careful with interpreting these, and you have to know what you're looking for. And most importantly, you can't just treat a number on a page, which is what a lot of providers do, and that's where we get in trouble. So we have to look at what are our numbers and what are our symptoms and really listen to what the patient's telling us to better understand what those numbers mean. So FSH and estradiol are going to fluctuate during that peri-menopause and menopause time. FSH, follicular stimulating hormone, this and estradiol are inverse of one another. So the higher the FSH, the lower the estrogen, and vice versa. So what studies have shown is that if you have a super high FSH, so if you're like in the hundreds with your FSH, even if you still have estrogen, you have a much higher chance of having more severe hot flashes and night sweats. We've also found that FSH can be elevated up to 10 years before menopause, but we'll know you're not in menopause because your estrogen levels will still be above 20. And so again, it's really looking at both. How do we evaluate those? What's happening with your symptoms? Again, estrogen levels are what tend to fall later in menopause and perimenopause. And then this is a newer one that some providers are using, and it's an interesting test. It's called AMH, or the anti-Müllerian hormone. And this is really looking at ovarian reserve. And it can help us predict somewhat of an age at where we'll be at menopause. It's not super widely used yet, but potentially one that might gain some traction here in the years to come. Okay, here's another good one that I hear a lot. And you may have heard this too. So you go to the doctor and they say, oh, you're just getting older. These are just things you have to live with. There's nothing we can do about it, which is what I used to tell people when I was in that traditional world. And again, this is not true. So our hormones, not only is menopause about how we feel and not feeling good and feeling different, but it's even more about what's happening to us post menopause and what are these hormones doing to keep us healthy. And so again, hormones are our fuel. They're very protective for our bones, our brain, our heart, our breast, all of those things. And it's really important that we refuel those tanks. Hormone HRT and BHRT is very different. And so when we're talking about treatment and what treatment options there are, it's super important to understand the difference between these. So hormone replacement therapy can mean anything. It can mean bioidentical, isomolecular, compounded, synthetic, oral, topical, injectable, anything. Then you have what you might see as BHRT, meaning bioidentical hormone replacement therapy. That's the most commonly understood word. I prefer isomolecular hormone replacement therapy. And what that means is the molecule that you're getting from whatever source we're getting it from, whether it's an implant or whatever that is identical to the hormones that your body naturally makes when it was making it. So those are super important to understand because all hormones, I don't know how well you can see me, but I'll use my hands just in case you can't. So all hormones work as a lock and key. Your hormone is the key and it has to attach to its lock or to its receptor for it to work. So if that hormone key molecularly is not what your body is making, it is not going to fit into that receptor exactly the way it should. That is where we see those side effects, the blood clots, the heart attack, the stroke, all of those things. And so we really need to make sure that key that we're giving, that molecular structure is the same. The other hormone therapy non-negotiables, in my opinion, this is just my personal opinion, is that three main things. Hormone therapy should always be individualized. I see way too many people come in and are like, oh yeah, my doctor put me on this patch or they gave me this estrogen and they didn't even check levels. They didn't know where my levels were at. So it has to be individual and it has to be specific for the person that you're seeing regarding their height, their weight, their numbers, their protein, their albumin, all of those things. The second thing I truly believe is it has to be the most natural product we can give them, meaning that isomolecular form. And then it really truly needs to be in the most natural delivery method we can give. So what I mean by that is finding a way to get those hormones back in a way that is stable and consistent. So unfortunately, if we're doing oral or if we're doing topical, what we're having is a more of a roller coaster effect of those hormones where you put on your cream, your levels go up and then they drop and then you have to apply more. Two main issues with that. Number one, you don't feel as good. So you feel good and then you don't, and then you feel good and then you don't. But the bigger issue, in my opinion, is that we don't have those stable, consistent levels. Like I said, estrogen at least over 30. It's not staying there consistently. So we don't get the long-term benefits and outcomes of having that hormone replacement being there. So when we use a subcutaneous implant, one of the best things about it is that it keeps those levels up. I usually tell patients if you are postmenopausal and you have no hormones, think of it as us giving you a new little ovary. So your ovaries literally just kind of shrivel up and die and atrophy inside of you once you're postmenopausal. And so we're just giving you a new little ovary that's releasing those hormones exactly like your body would when it was still doing that. Sarah, I'm reading your question here. Is there a way to increase balance or hormones with certain foods? That's a little bit of a loaded question. And partly it is because it will depend on where you're at and where your hormones truly are. So there are some foods that are just going to help, and when I think about that, I think of that more in the gut space and how we have hormone receptors in our gut. And so looking at what foods are affecting our gut, those inflammatory foods, those types of things. But if you have truly postmenopausal levels or very low levels of hormones, it's going to be really hard to get those to a therapeutic range through diet alone. Okay, I think I'm almost done. Last one, bioidentical hormone replacement is not regulated. Oh yeah, this is a great one. So I hear this a lot too. So, you go to your doctor and they say, no, don't do that hormone therapy thing. It's not regulated. Those compounding pharmacies aren't safe. We don't know where they get their medication. That is also wrong, for me to say it nicely. So 503, there are different types of compounding pharmacies, 503A pharmacies and 503B pharmacies. 503B pharmacies are regulated by the FDA and have the same CGMP regulations as mainstream pharmaceutical manufacturers. So their methods, their facilities, their testing, their packaging, their processing, all of that is the same, and it is regulated, and they do have to meet those same standards as long as you're using a 503B pharmacy. The other important thing that your provider might not tell you is the accepted variance rate, not just in compounding medications, but also in our generic and our brand name medications. So if you are on anything, any sort of medication, or you go and get ibuprofen over the counter, or you're on a generic medication, the acceptable variance rate by the FDA is 30%. So what that means, say you have progesterone, 100 milligrams, it can vary by more, 30% more or 30% less of that actual dose that you're getting. This is why so many women who are on birth control are like, oh, this month my birth control didn't work, or I had all this bleeding. When we're messing with hormones and we're changing those up and there's an accepted 30% variance, you are going to see issues like that start to happen. So generic accepted variance rate by the FDA for a generic prescription is 30%. A brand name, brand variance rate accepted is about 10%. So it's better. Compounding pharmacies that we specifically work with and that a lot of people work with have a 10% variance rate. Or sorry, a 3% variance rate with the compounding pharmacies. And so that's really where it does matter. Who are you using? What are their standards? What are their processes? And I would argue that some of our compounding pharmacies are actually better regulated and more regulated than some of our generic manufacturers and pharmacies. I mentioned this earlier. You do have to be careful because not all bioidentical hormone therapy or hormone therapy is created equal. So you have to make sure you know where you're getting it and how is it being prescribed. Okay, I think that is the end of my piece here. So the part I was most excited for was for Tara to kind of jump in and share her story. If there are any burning questions, let me know. But otherwise, I would love to just kind of have Tara tell us about yourself. And yeah, just start with who you are and who you are. Yeah, that's great.
Okay. Okay, my name is Tara. I'm 50 years old. I'm married. I have 3 girls, ages 22, 20, and 18. And my baby is soon to be graduating, so I will be an empty nester, my husband and I, which is very exciting. I'm nervous, can you tell? I've been active my whole life. So, gosh, ever since I can remember, I've been active. I was a runner in college. I was actually All-American in both cross country and track. And I always thought, well, I do, I know. I prided myself on knowing my body. And when last year, it was over Mother's Day weekend, something was off, just felt not right. And I had lost my mom. It will be 3 years in this coming July. And I thought, because it was Mother's Day weekend, I thought maybe I was just grieving her. And my dad had started dating again. So I just was like, oh, it's probably just that. Like, I'm feeling down. I'm just feeling down. And yeah, it was kind of the start of the downward spiral, I guess. So that's a little bit about myself. What else do you want to know?
I love it. You kind of touched on this a little bit. So how do you kind of talked about before menopause and perimenopause, how you were feeling? So you felt like you were in good shape, you were active, you didn't have any like major mood concerns, like things were good.
No. So before, I actually think that I sat down, thought about this, but I really think I started perimenopause about 10 years ago. So when I was 40, sadly, when I was 37, we had a big family tragedy or trauma, and we lost my sister's 2-year-old. to a drowning, which happened at my youngest and my middle daughter's birthday party. So that was something that happened 13 years ago, but at age 4, like, so I was, before then I was able to handle everything. I had my oldest when I was in dental school. I was able to graduate on time, get all my credits done. Like, you just go. I never worked full time, but I did work part time. Had 3 girls. We traveled around for my husband's job, and I was always able to juggle. There was no problem. Like, I was tired, but yet when I hit my pillow, I slept like a rock, was able to get up. And my husband can attest, when my alarm would go off, I would be in the shower like 5 minutes before my alarm would go off. Like, I just had a lot of energy. Um, and then I would say right around 40, so 3 years after the accident, I kind of hit a wall. And I would be driving to work. So we had moved to Stillwater, or we lived in Stillwater. And then after my sister's, or after our tragedy, we moved to Edina so I could be closer to my sister, to just kind of help her with her kids and stuff. And I would travel back to Stillwater to work. And I remember talking to my husband one night and was like, there's something wrong with me. Like, instead of going to work, I want to drive off the bridge. Like, I don't know what is going on. And he's like, okay. And then I was never an owner of a dental practice. I always was an associate. So I practiced with a dentist who I totally loved. He's a ginger as well. Everyone he hires is gingers, which is not really, but kind of. So we got along really well, and he was the third dentist that I actually worked with during my career. And I said, when I started working with him, I'm like, if this doesn't work, I'm quitting dentistry. Like, I cannot, it's super hard to find someone that you can practice with. So we got along great. And finally I went to him and I was like, John, there's something wrong with me. Like, I want to drive off the bridge instead of coming to work. And I'm praying the whole way on my way to work that my patients do not have any work to do, which is totally not what you want to do as a practicing dentist. You actually want to have patients that come in and you want to provide them with your best services. So he sat me down and he was like, Tara, your heart was broken 3 years ago. And I'm so glad that you came to this realization, because I didn't want to tell you. I needed you to come to this on your own, but you need to stop and you need to take care of yourself. And your production sucks, basically, is what he said. So I ended up resigning, and I spent a whole year in therapy every week. It was the hardest thing I ever did. Um, it was hard, but I got that trauma from right here to out in the world. And I could go about my day without constantly thinking about it, which was good. And then I tried to go back, and it came right back. Because when I was during the tragedy, my brother was doing CPR, I was holding my little nephew's head, and that is exactly where your patients are when you go to work. So here's me thinking, I mean, I was diagnosed with PTSD, but I also think it was happening the same time as my peri-menopause. So it's like compounding. And I went to my doctor and I asked for an anti-anxiety. And she was happy to give it to me. I really like my doctor, by the way. I like her a lot. So she was happy to give it to me, and then great, functioned well, got out of the hole, was able to move on. I never went back to dentistry, but I was able to function. Um, and then fast forward to 2020. And my oldest, it was a pandemic, obviously, and my oldest graduated from high school and decided she wanted to go to St. Lawrence University, which is in upstate New York. So our whole family dynamic changed. I launched my baby into a pandemic across the United States, which was super hard to do. So then again, I found myself like really being sad. Obviously, it's kind of a normal thing when your whole family dynamic changes. But again, I went to my doctor and I was like, okay, this anti-anxiety is not working. Can we up it? Can I do an antidepressant? And she's like, sure. So we did, and that worked. And I was on 100 milligrams of sertraline and 150 milligrams of bupropion, or Wellbutrin, which worked. Again, it got me out of the hole. I was able to function. But the side effects of those, when you compound them, I didn't notice so much with the sertraline, but with the antidepressant, it causes a lot of dry mouth. And it just worried me being a dentist that I constantly would have dry mouth. And then also, you know, you have changes with um, your sexual function. I mean, you just, everything kind of changes and you are just not in the mood and you're whatever, the whole thing. Um, so yeah, so that's kind of long-winded way to answer that, but that brought me to 2020. Um, and then fast forward, so this fast forward to January of 2023, I decided I was going to cold turkey go off my meds because I was sick of being on them. And I didn't consult with my doctor, didn't consult with anyone, basically, didn't even tell my husband. I just stopped taking them. Which, yes, I did have a headache and some brain zaps for about 5 to 7 days, which is normal if you just go cold turkey off of them. That's why you're supposed to wean them. So everybody just wean. But I was fine. I felt awesome. And it was 4.5 months where I had never felt better in my entire life. I had energy, and I could think clearly. It was amazing. I mean, ask my husband, I had all these ideas and like, just, it was amazing. And then get to Mother's Day weekend and it came to a halt. But I do think that I pretty much threw myself under the bus because I don't know if I told you this, Jackie. In February, I started doing intermittent fasting. And intermittent fasting is awesome, but if you research it, one of the main things was if you have ever been diagnosed with an eating disorder, you need to be under the supervision of a physician. I was a runner in college. I never was diagnosed with an eating disorder, but I guarantee I had one. So when you start fasting, you can go a long time. And I'm a super competitive person. I could go a long time. Typically, you're supposed to do like 36-hour fast, maybe once or twice a week. I was doing them more than that, which was not good. So pretty much, and I wasn't taking supplements. Pretty sure I threw my body into that mess. I guarantee I did. So I was having a lot of anxiety. I knew that my cortisol levels were through the roof in the morning because I would wake up, I'd be just shaking. And instead of getting up before my alarm would go off, I would not want to get out of bed. And unfortunately, my husband was gone during the week, came home on the weekends. And luckily, my girls were here though, because I was super close to taking my own life just because I didn't feel good. I didn't know why I was having so much anxiety. And then of course, having so much anxiety, then it also turned into, I wasn't hungry because of the anxiety levels. So when I went to my doctor at the end of June, and you know, you get on the scale. I don't have a scale at home. I never weigh myself. But I was significantly less than the last time I had been to the doctor. And I was like, oh, geez, that's probably not good. So at the end of June, I felt deflated because I went to her kind of wanting more help with the menopause or the perimenopause, but was like, okay, I think I messed up. I shouldn't have gone off my meds. I probably need to be on them. I guess I need to be back on them. So she was like, okay, you know, it's not a big deal. Don't get stressed out, tear out. Like a lot of people are on this. Let's just try. So she said, you know the drill. After about 2 weeks, you're going to start feeling better. Well, it was like 6 weeks later and nothing touched my anxiety in the morning. My most favorite time of the day was at night because I could go to bed and not have to deal with anything until the next morning. But the one thing that got me through was that I had in my regimen working out. And I didn't do it every day, but I either worked out at a little club in Edina with my sister, or I would take my dogs for a walk, or I'd go for a run. So I did do that, and that I feel like that little bit of endorphins that I put out during the morning helped me get through to the afternoon. Because right around 3 o'clock, my cortisol, I think, levels would drop, and then I would feel normal again. And I was like, oh, well, tomorrow I'll be fine. Like I'm totally fine because tomorrow I'll be better. I'm fine. I feel better right now. And my sister would call me every morning to check in, and I'd put on a happy face and be like, oh, yeah, I'm fine. Oh, this is great. Well, I have two little amazingly cute dogs, and I literally wanted to cut their heads off. Like, I was that annoyed. It was so bad. I really wanted to let them go. And we have coyotes that come, we're in the middle of Edina, and there's so many coyotes and wildlife that comes through our backyard. I wanted to let them out and sadly, like, have them being taken away by the coyotes. So sad. Um, and the other thing, last summer, I spent the summer when my husband was not here on my couch, not drinking or doing drugs, but reading romance novels to get my mind in a place that was good and not thinking about ending my life, because that's what I wanted to do because it was just so bad. So yeah, so that's my story. That was long.
That's great.
Well, but I didn't know about going to see Jackie. So, okay, so then in September, I went to my OB because, you know, of course it takes forever to get into your OB. And I go to my OB and I tell her, okay, I definitely need a hormone panel because my hormones are messed up and I need help. And she was like, well, you're 50. Of course your hormones are messed up. Like, we're not going to do a blood panel. I was like, why? Like, what? Seriously? So when you go to the doctor and you fill out your mental health form, I was all the way to the bad side. Bad, everything. Every question was to the negative side. So now that I think about it, I left that appointment and I had so many questions. I brought my notebook and I was asking her about stuff. And she's like, the only thing I can do is give you an HRT, which, you know, great. And I was asking, I'm like, okay, what are you going to give me? And she's like, I'm going to give you estradiol pills and progesterone pills. And I was like, okay, well, why would you do that? You know, asking. And she was getting irritated with me. She's affiliated with a hospital. So I guarantee she had a person that was in labor, because I could tell that she just needed to be done with me. Like, she didn't want anything to do with me. I'm never going to go see her again. But anyways, I walked out of that appointment completely lost. Like, I did not know what to do. And the appointment was in Burnsville. And I wanted to drive off the 35W bridge on my way home because I didn't know where to go. I'm like, my doctor is not really going to help me. And my OB doesn't want to do a blood panel. So what am I going to do? I have no idea. So that was the end of September. And in the middle of September, I joined BSF, which is Bible Study Fellowship, for those of you that know. And my leader was 65. So after the first session, I went up to her and I said, Linda, I'm coming to this weekly, but you don't call on me because it's super intense. If I don't do my lessons for the week and you call on me, I will literally break down and I will never come again. But I need to come because I need to get out of the house. And I just need to do this. And she was like, okay, I won't call on you. And then I asked her about her journey with peri-menopause. And she's like, oh, sadly for you, I had a hysterectomy, so I never went through anything. And I was like, okay. She said, but I just heard this woman on a podcast. I don't know her, but I heard her name is Jackie. She owns Flourish Medical and Wellness. You should look her up. So that day I got home, I looked her up, and unfortunately, I was like, well, Jackie's a nurse practitioner. She's not a doctor. What's she going to know? She doesn't. I mean, my doctor can't even help me. So how is she going to help me? So I kept researching, like, kept looking at stuff. Like, I was intrigued by her whole website. And then I just, you know, put it off. And finally, right around early December, my girls were coming home for Christmas, my older two that were in college. And if the mom doesn't put on Christmas, sorry, dear, Christmas doesn't happen in your house. Thankfully, Christmas last year for us was going to be different anyways, because my middle daughter was skiing in some Nordic ski races out in Utah. So in order to have Christmas as a family, we had to go to her, which was great. Because I couldn't fathom even I did do a little bit of decorating, but I couldn't even fathom buying a present. And the one present that my husband and I bought was a $5 puzzle from Menards, and it ended up to be the best gift that we could have given our girls, because we're all competitive. And so we put it together, and the girls could care less if we had presents or not. So that was my story. And then I made appointments because they were coming home. I called Jackie's office, and of course I couldn't get in until I saw her February 9th. And that day I went into her office, and you can tell them what you saw, Jackie.
I was shocked. Can I just be super honest and
Totally.
open? So we have an option for patients to upload a photo to their chart. I may
Yes.
have shared this with you. I don't remember if I
I
did.
don't know.
And I remember looking at your chart before I went, and I'm like, oh my God, like this woman looks like life is really hard. Like that's what I remember thinking. Like you just like the way you look now, that is not how you looked when I saw
Mm-mm.
you. Like your eyes were different, your skin's different, your like everything about you was just completely different. Um, that's what I don't know if I ever shared that with you, but
Yeah,
you
you
look
did.
like a completely different person. So
Hmm.
so keep going.
Yeah.
So then you came in.
Yeah.
I what was it different? Like what was different about kind of our visit compared to what you had
Oh,
had
yes.
from other providers?
Okay, so when I sat down with Jackie, I had the night before I had written in my notebook like literally 3 pages of everything that happened that I had done to my body or that had happened to my body in the last year. And I sat down and I looked at her and I'm like, "How long do I have?" And she was like, "Excuse me?" I'm like, "How long do I have? Like 10 minutes, 15 minutes? Like, do I have to really go through my notes or how long?" And she goes, "Oh, honey, as long as it takes." And I was like, I pretty much started crying and I was like, "Thank God I found the person that is going to help me." Like, I knew before she even said one word that she was going to change my life. And it totally was true. So, and I mean, she asked questions. I told her my story. And it was an hour of an appointment that we had. And I got everything out and I just felt so much better. I just felt like I was in really good hands with Jackie.
And we
So
did your labs.
we did, yes. So we did labs. And then a week later I
We
went
didn't
back.
guess.
It was yes, we did. I didn't even have to ask. She was like, "And we're gonna do your labs." I'm like, "Yes, okay." So I went back a week later, and ironically, it was February 13th. And for those of you that know me, 13 is an unlucky number, but yet it's a lucky number because this year was 13 years on the 13th, so the golden anniversary of the loss of my nephew. Um, but things, it's funny because when you look for those little signs, they're all over the place. And he and my mom were definitely with me on this journey. Oh, now I'm getting a little sad. Or like, whoo. Anyways, so I went back on the 13th and I knew what Jackie was gonna say, what she recommended because I had done my research and she was like, "This is what I recommend." And I was like, "Yep, sign me up for whatever you recommend." And she's like, "And I think because your testosterone is 0, and I don't have my numbers in front of me, like my labs, I should, but my testosterone, and if I'm wrong, Jackie, let me know, should be between 150 and 250 or like 150 to 225 or something like that."
Yeah.
Okay, I was 0, people. And testosterone runs everything in your body. So I was not wrong when I said my hormones were off. And I knew that something was wrong. So Jackie was like, "Okay, we're gonna do BioT." And it was a little testosterone pellet and put it in my little butt or my whatever butt. And she's like, "And I'm going to boost you because I've never seen anyone as low as you." And I was like, "Okay, whatever you recommend." Um, so she did, and literally it took 3 days. And you can ask my husband. My life was like turned upside down, meaning in a good way. Like I got my life back. I had my energy back, even more so. Um, Everyone around me like thinks that, well, the patients that you've seen, Jackie, are like, "I don't want to be like Tara." Like they go in there like, "I don't want to be like her," including my own sister. But because my testosterone, because Jackie boosted it, I had a lot of testosterone, and so I felt like a 15-year-old boy, which meant that normally I never wanted to have sex, but now I wanted to have sex all the time. And my husband was like, "Oh my God, what is wrong with you?" And he was worried because he had seen me last year, like on this really big high, and then all of a sudden crash. And so he kept saying, "Okay, I'm super worried. Like, this is freaking me out because you crashed last year. And how low are you going to go this time? Because you were really low last time." And I was like, no, this is different. Like I have my supplements. Oh, also, Jackie, besides the BioT, she had done a full lab panel. I found out that my cholesterol was at 298. My A1C was a 7, which means I was diabetic at 110 pounds. And I always had high cholesterol, but my HDLs were always high. So it was good, or it was fine. But this time my HDLs were not good. And so that sort of freaked me out. I forget what else was bad. Can't remember, but anyways, so I have a ton of supplements that I take, and I'm religious now about I'm not taking any meds, like prescribed meds, just my supplements. Um, and now I forgot what I was supposed to say.
So I honestly did not eat, well, I didn't even know what you were saying, right? I know your story a little bit, but
Yeah.
it's super interesting looking back and then thinking about everything we just talked about for the last hour and the research, right? And so this is where research and actual practice, and they really line up if you're digging in. So moods, depression, right? 62% of people, that was huge for you. The
Hmm.
change in your HDL and your LDL, right? When
Yep.
your hormones drop, we're going to see your HDL drop and your LDL go up. We're going to see diabetes, right? So all of these things that you were seeing, that we saw for you, are literally, textbook from what we see for
Mhm.
so many women, but the treatment recommendation is sertraline or
Right.
Wellbutrin or an
Right.
antidepressant, which
Right.
is
Right.
not
Right.
something that your body makes. That is not the fuel that your body is needing. And so um, it's amazing to hear you just share all of that and kind of what you've experienced and the real life of that. Like it's something for me to sit up here and say, this is what I see and this is what the research says,
Mhm.
right? But when you hear from somebody who lives it, who's gone through it and is open and willing to share and be vulnerable, I think
Mhm.
it helps so many people in so many ways. So I really appreciate that. If you could tell people, like
Yeah.
one or two things, like like, what would you tell them?
First of all, I would be your own advocate. When I went to see Jackie, I was like, our medical system is messed up. Like, if patients came to see me, I would not send them home with a bottle of pills. I would figure out why their tooth hurt, right? Like, what in the world? So definitely be your own advocate. If you feel like something is wrong, it is, and you know your body. You're the one that's in your body, so you know your body. Don't, if you are having a gut feeling of, wait, I'm just not agreeing with that, um, then yeah, go with the gut feeling for sure. So,
Love it.
let's see, what's the second thing? I don't find a practitioner that will listen to you and not spend 10 minutes. I mean, literally, yeah, someone that is educated on that. Like Jackie.
And I think that's great. I get asked a lot of questions, what is your opinion on vaccines and, all these controversial things. And I think if I could leave anyone, I'm not saying come see me, like you need to find the right fit for you. But if you have a provider who is extreme one way or the other, like 100% anti-vaccines or 100% you have to have vaccines in any way, like could be anything, not just vaccines, right? Or
Mhm.
100% hormone therapy is bad, or yes, hormone, like be careful, right? Because it's never one or the other. Medicine is not like that. There is a large area, a large gray zone, and it really should be individualized. And so I totally agree. Like that's great advice for people is listen, you better than I do, right? And I always tell people,
Yeah.
I'm not going to sit here and tell you what to do. I want to help educate you so you know your body, and then we need to work as a team to figure out what your body's needing. So that's awesome.
Yeah.
I had a question from Jen. She said, what is your opinion on progesterone with the hysterectomy and ovaries still there? Jen, what can I ask how old you are?
Sure. And I didn't mean to take away from Tara's story.
Oh, you're
Oh,
good.
And
Jen,
first of all,
don't
I've known
worry.
Tara for like 40
time.
years probably. And so
Love
I
it.
was just very weepy hearing the story. So I apologize for that. It was beautiful. Thank you, Tara, for sharing. I am 51.
Okay. I don't know that I touched on this. I think it may have been in my slide somewhere, but that's kind of the median range or average for women from postmenopause in the United States. So without us knowing labs are going to be important because it's going to help me know truly where are you at in that cycle. But most likely, progesterone is something you're not making a lot of. Okay. Now, this is not black and white because you don't need progesterone if you don't have a uterus. The reason that we have to use progesterone if we're giving estrogen for hormone therapy is because it has to keep the lining thin. We don't want you to start the uterine lining thin so that you don't have a thickened lining causing cancer, right? You don't have that. So you don't have to worry about that. So progesterone isn't necessary per se, but if you're menopausal, you're not going to have it. So then we lose out on things like it's our body's natural diuretic, it is our body's natural sleep hormone, central weight gain, like keeping estrogen in balance. So there are a lot of things that progesterone does that could still be very helpful for you. And so I would typically base that on like, what are your labs looking like? And then what are your symptoms? Because if you're having difficulty with sleep, if you're having central weight gain, if you're feeling like you retain fluid, if you feel like your hot flashes or night stuff isn't well controlled, it can really help with that. So you wouldn't need it, but it can be very helpful.
Okay, thanks. Check all the things you said, and my hormones are very low. So, but I just
Yes.
keep hearing from my regular doctor that they just keep saying, no, you don't need it because you don't have a uterus. But things I've read and heard are different. And so thank you
Yeah,
for that.
yeah, for sure. And that's really where that whole like treat the patient, not the number is so important. Numbers are important. They're a great guide, but we really have to look at the patient and the whole picture and all of their symptoms as far as um, being able to provide, optimal treatment as well. This time went really fast. I didn't think it would even take us an hour, so I apologize that we're over time. I will try to get the slides sent out. I have your emails, so I can send out slides if you guys would like those. Feel free to respond if you do have any other kind of questions that you would like feedback on offline. Happy to do that as well. And Tara, thank you so much for sharing and for just the blessing that you are to me and so many others. And being vulnerable, because I think, women are a lot of times they find themselves in a similar situation and they feel like they're alone, they're on an island and they're afraid to share. So that is super helpful. And then I don't sound as crazy either.
Right? No. Oh gosh, no. You're not crazy.
I don't know if you can see the comments, Tara, but we had a lot of love coming your way.
Oh, thanks, girls. And guys.
So yes. Nothing from Tom. So Tom, you better get on that. But
Right.
you're amazing. Thanks for being vulnerable and sharing with us. Your story is familiar. I hear similarities in my own. Tara, you are remarkable. Love you for sharing this. You are amazing. Yeah. So lots of
Well,
love coming your way.
I will share, Jackie, when I was going through this really hard time last summer, I only told a handful of people, my husband, my girls, my sister, my brother-in-law, and my dad, and we're all strong in our faith. And when I would get down on my hands and knees every morning, when I was talking with God, I would be like, God, not if you get me through this, but when you get me through this, I will be your hands and feet and I will not be quiet about this. I'm going to be a loud one and get the word out. And so that is what I'm trying to do. And that's my new goal. And I actually want to be a professional speaker someday. Not that I will ever get to do that, but
You totally do that.
I would love to speak on this topic because I am super passionate about it, which is the funny thing is I was interested in this last January, so January of 2023. But for those of us that are Christians, God had a different plan. He's like, great, Tara, I'm so happy you want to be a speaker, but you do not know what it's like to go through the lowest of the low. So I knew that he had a plan for me, and my life verse is actually Jeremiah 29:11. So that got me through. So if I can just touch one person's life, change one life, I've done my job.
All right, ladies, please, like I said, reach out and have a great evening.